Okay, so this is Unit 2A, Part 1, the effects of hospitalization on children. I'm going to try and make this as quick and painless as possible because the slideshow is very long. So I'm not going to read every slide to you. You can certainly do that on your own, but I'm going to highlight what I think is important and probably what you think is important. All right, so children's understanding of health and illness according to the developmental level. Obviously, anytime a child is hospitalized, it is very stressful on the child, on the family, on everybody. And the goal as the nurse is that you want to minimize the stress and provide support and education to both the children and the families. All of these can contribute to the child's ability to cope with this hospitalization. And there is a great table, 11.1 on page 224, that breaks it down based on their developmental level. We're going to go into that more in depth, but it will give you a good overview if you want to look at it. So hospitalization disrupts the routine of not only the child, but of the parents. So you need to think about the parent stress as well. If they are anxious, it certainly is going to contribute to the anxiety of the child and probably your anxiety as well. The parents are missing work, if they have other children, if they have other people that they're taking care of. You need to consider all of these things. And nursing support has been proven to decrease parent anxiety, which in effect decreases patient anxiety and hopefully your anxiety. Okay, so infants, we're going back to Erikson. It's all about trust versus mistrust. They are exposed to painful procedures, and they also are having their routine disrupted. They're getting no sleep, which is not a good thing at all for an infant. We'll talk about separation anxiety on the next slide, but I did want you to know that stranger anxiety, this is important, develops around 6 to 18 months of age. So if you have an infant less than 6 months, they may not be as hesitant to come to you, but certainly if they are 6 to 18 months of age, they are very aware that they have no clue who you are. Separation anxiety, there are 3 stages. I encourage you to look at table 13.3 on page 409. And it's pretty self-explanatory. Stage 1 is protest, so the stage is going to protest, or the child is going to protest. Stage 2 is despair, so the child is going to be upset. Stage 3 is detachment or denial, and so the infant will detach from the parents. You can read this on your own. Again, pretty self-explanatory. Nursing care, this is where you come into play. Encourage the parents to room in with the child as much as they can. This is hard when we have semi-private rooms and only one recliner, but do the best that you can. I have, even in the ER, wheeled in 2 stretchers, so the parents could sleep on one stretcher and the child could sleep on another. It's not ideal, and I probably wouldn't do it every night, but you do what you need to do to, provide the best care that you can possible. Continuity of caregivers is important, so this is where primary nursing comes into play. The parents develop a relationship and rapport with the nurses, and there's a sense of trust there as well. Maintain home routines as best you can. they read before they go to bed, provide them a book. You know, if they brush their teeth at a certain time, do that as best they can. This is hard in the hospital. Allow expression of the feelings. Again, open, honest communication is the best way that you can care for these patients and families. If they need to get out some anger, they can pound some clay, throw some bean bags. I'm sure Child Life's got all kinds of things that they can do. You can also encourage parents to bring personal belongings from home to make them feel more at home. I know that a lot of the chronic children, their parents will bring sheets and pillows from home just to make them feel a little bit better. So again, with protest, you want to encourage the parent to say goodbye to the child. We encourage honesty with them. You know, make sure the parents tell them that they love their child. This may not be it may not be a healthy family in general, and they may not express their love in a healthy way, but encourage the parents to tell the child that they love them and to visit often and to let them know when they'll be back. To call them on, you know, you can provide a hospital phone for them, or if the child has a cell phone or whatever, just so that they know that the parent cares even if they can't be there with them. Despair, again, you can read to yourself. Nursing care, where you come into play. Like I said, be sure you have consistent caregivers or a primary nurse. Tell the child when the parents will return using a timetable that child can understand. So you can draw on the clock or on the whiteboard and let them know when their parents will get there so that they aren't ringing out for you every 5 minutes and want to know when their parents get there. And then continue other interventions that we've already discussed. Detachment, you can read for yourself. Nursing care, this one is hard for the parents, and so you need to help them to understand that it is a normal developmental reaction. The child will ignore the parents and may cling to you, especially if you're their primary nurse. But encourage the child to express their feelings and let the parents know, again, that it's normal. And most of the time, the child will warm up to the parents before you leave the room anyways. All right, so how you as a nurse are going to address pediatric patients. They all require something different. So nursing care of infants, you want to use a calm, soothing voice. You want to respond to the cries quickly because you don't know what's going on. And we talked earlier about the parents letting you know what their cries sound like. You want to talk to the infant before and during care. It's something I learned taking care of adults, that even if they can't speak to you or respond to you, that you still talk to them like a normal human being. Let them know what you're doing. Don't necessarily do baby talk to them because, you know, using adult words and words that they will probably hear later on in their life helps them to develop their vocabulary. You can prepare in the room. For infants, you don't have to prepare outside of the room, obviously, because they don't really know what's going on. Use a slow approach. Don't be rushed, because if you are rushed and anxious, the infant will become rushed and anxious. Do allow the child time to get to know you. You can hold them, you can talk to them, you can rub their belly, do whatever. Encourage parental presence if the parents can handle it. There's some parents that don't like being in the room when their child's getting an IV or something like that, and you respect that as a nurse and let them kind of guide if they're going to be there or not. Reduce excessive stimuli, turn the lights down low, all of that when you leave. Use topical anesthetics or pre-procedural sedation as prescribed. Toddler's reaction. We're going back to autonomy versus shame and doubt. You can read this. Sorry, I had to flip my page. You can also read this. Nursing comes in. You want to know what words they use for pain and going to the bathroom and all of that if they're potty trained. You want to know what they use, and you certainly want to report off those words to the next nurse so that you're talking to the toddler in a way that they can understand. You want to describe the activities and procedures when you're about to do them. Don't describe them too early, because then they can get anxious and you will literally have to tackle them to the bed. You can use picture books, you can use play for demonstration, you can use a doll and put an IV in a doll and stuff like that. Child Life is good about that. Approach the child only after giving them time to warm up to you. Again, you want to encourage parental presence. Here you want to think about if the parents are willing to hold them during the procedure or during your assessment, that's totally fine. And also you want to kneel down to their eye level so that you're looking in their eye level. Eye contact is important for adults. It's also important for even toddlers to develop trust with you. So you want to be sure that you're at their eye level. And I remember there was a HEMONC patient who would not sit still for you to access her port in the bed, but if mom held her and held her arms back, she would sit still for you to access her port. So by God, and she was way calmer. So I definitely always let mom hold her while we access her port. It's not always going to work out like that, but discuss with the parents what they feel comfortable with. Preschoolers' reaction goes back to initiative versus guilt. I will let you read this. Again, illness is a punishment, just like death, we talk about later. Nursing care for a preschooler, we're going to go back to that Erikson stage and offer choices when they exist. So obviously giving them medication or putting in an IV is not a choice. However, you can give them a choice of what they want to watch TV, or what flavor popsicle they want afterwards, or what juice they want afterwards, or things like that. You want to offer them choices when you can, but there's some things that are just not a choice. You can use play to explain, speak in simple sentences to them, and again, encourage parental presence. You want to describe the activities and the procedures as you're about to do them. Again, don't describe them way in advance. They will freak out. Limit it to less than 5 minutes. I have known coworkers to ramble on and on for 30 minutes, and then you've completely lost the parents and the child and 30 minutes of time that you could have been doing other work. You want to engage in prep activities if you can. This is where Child Life may come into play. School agers' reaction to hospitalization. Again, we go back to industry versus inferiority, which we have already talked about. So you can read that. Nursing care of school agers, or children that are school aged. They can actually think and understand about their body and illnesses, and so you can really speak to them more in a mature, for some people, and a more logical way. Again, you still want to encourage their parental participation, though. You do want to establish limits and set consequences, because if not, they're going to abuse if they have no limits. You can use medical play techniques. They do feel a lot of times bored and separated, and so you can encourage peer interaction. There are a couple ways you can do this. There's certainly playrooms available in the hospital. You can provide age-appropriate toys to them. Obviously, you're not going to set them up with a bunch of blocks and tell them to play with the blocks. You would, provide video games or card games or board games or something that they play at home, and maybe you can play them, or maybe a nursing student's there for the day and they can play with them. It also may be helpful to have peer support groups or connect them. It's kind of an interesting phenomenon for the playroom. Can actually introduce teenagers that may have the same diagnosis as each other, and so maybe one of them is really compliant and one of them is not, and so the compliant one can be a good influence on the teenager. There are a lot of support groups out there for teenagers, though, and you can certainly contact social work and give this information to the parents. Adolescence, identity versus role confusion. We've talked about that. You want to engage in things that they enjoy. You want to use a collaborative approach, and then foster the child's independence as much as you can. Still want to include parental environment, though, because who doesn't need their parents? With adolescents, you can introduce prep material up to a week in advance. This will give them time to prepare, to research, to really grasp what's going to happen to them. And so adolescents you can treat more like adults, but they aren't fully adults yet. We've talked about common parental reactions already a little bit. Main thing for nurses is to provide support and education and participation to the parents. Certainly encourage them to be involved and at the hospital as much as they can be, and provide them for resources outside of the hospital if they need it. You have probably already worked with dysfunctional and functional families. This certainly carries over into a hospitalization of a child, so just be aware of that. Be aware of these factors. You can read this. We have talked about this already. For education, you want to teach the parents and the children about all of these things. And again, you want to be as honest and as open as possible, but you want to make it age appropriate, and you want to consider not only their numerical age, but their developmental age as well. You obviously want to encourage the parent to assist with the child's care. I know a lot of, some chronic parents' children want to do it all, and that's fine as long as you can do your assessment and do what you need to do. You certainly don't want them touching IV pumps or anything like that, but setting those boundaries at the beginning of your shift is important. But if they want to feed and bathe the child and change the child and put the child to bed and read to the child and all of that, that's all fantastic and keeps the child as close to their routine as possible. As a nurse, you want to support the family, support the child. These are all ways that you can do that. We've talked about promoting coping with children. Child Life, like I said, is a great resource that you can use. Therapeutic play is another thing that you can do to promote coping. This is where it's guided by members of the healthcare team, and it meets the child's physical and psychological needs, and it provides the child an emotional outlook. It's also educational to us because you can gain insight into the child's thoughts or feelings, likes or dislikes, wants or needs. basically the child's telling the nurse through words or actions about fears or concerns. So, for example, you have a doll and you're engaging in therapeutic play with a 4-year-old who wants to play the doctor, and she may be assessing the child or listening to the child, and the 4-year-old may have a heart problem, and she may be telling the child that she has a heart problem, but then may be comforting the child in a certain way, and so you can gain knowledge on how to provide comfort to her. That's just one example. These are other examples of types of therapeutic play. The table is wrong at the bottom. It is table 1110 on page 240 if you want to see more about that. I will say be careful with needle play, but what a lot of us did before, if the children were old enough and could understand, we obviously would not give them the IV, but what we would do is we would take the catheter, we would thread the catheter off of the needle, and we would show the child the catheter so that the child would be aware that the catheter is actually what's in their vein, not the needle. And so the needle will hurt initially, but again, it's this little plastic soft thing that is not going to hurt you once it is in your body. And so that's another way that you can educate the family and the child. Which I basically just talked about this. The nurse in the outpatient setting, or even inpatient in the hospital, if they're having a procedure done, certainly can play a big role in explaining to the child what's going on, what they can expect, and decrease the fears of anxieties of both the child and the family, like we've talked about. Again, consider the child's cognitive development, not just their numerical age. Visual aids are always great. Just like for students, for you guys to learn, it's also great for children and your patients to learn as well. You can allow the child to practice. So in the IV example earlier, we would always give the catheter to the child so they could feel exactly what it felt like, so they knew what was going in their body. So again, you're using those senses to calm them down a little bit. We have talked about preparation strategies already. You can certainly read that again. Like I said, we've talked about this, and that is it. I kept it to 23 minutes. Let me know if you have any questions.